My name is Magnus Toe, and I'm a PGY1 at Riverside Community Hospital. My presentation is on metastatic cardiac tumor presenting as an acute myocardial infarction. So cardiac tumors are rare. According to a study from McAllister in 1978, their incidence rate was estimated to be 0.02%, most of which are benign. And of all cardiac tumors, it is estimated that about 10% are metastatic in origin, while 90% being cardiac in origin. And it's believed that majority of the 90% are from cardiac myxomas. In our case, we have a 45-year-old lady with history of DVT, PE, cervical cancer, status post-chemotherapy, and radiation. She presented to our hospital with chest pain that's been ongoing for about 2 weeks, described as substernal and pleuritic in nature, and is alleviated when leaning to her right side. She also endorsed dyspnea on exertion. EKG showed ST elevation in the anterior and lateral leads, and her troponins were elevated, peaking at 0.506. She was urgently taken to the cath lab, showing distal LAD occlusion, and was successfully treated with angioplasty. An echo following the intervention showed a mass and pericardial effusion, as seen in figure 1A and 1B. The arrows are pointing to the pericardial effusion, and the arrowhead is pointing to the mass. It was unclear to us at this point whether the mass was a thrombus or a cancer. We decided to pursue cardiac MRI to further evaluate the mass, as seen in figure 3. Again, the arrows are pointing to the pericardial effusion, and the arrowhead is pointing to the mass. Again, it was still unclear to us whether the mass was a thrombus or cancer, and we decided to call the patient's gynecologic oncologist. On contacting her gynecologic oncologist, we were told that a PET done 5 months prior to presentation at our hospital showed no abnormality in the heart. And so we consulted our cardiothoracic surgeon for a left thoracostomy pericardial window to visualize the mass, and this can be seen in figure 4. We couldn't remove the mass because of the degree of invasion into the pericardium and myocardium. However, we were able to obtain a specimen for pathology. And pathology of the mass showed pleomorphic cells, as seen in figure 2A, and keratin pearls, as seen in figure 2B. Immunochemistry staining was done on the specimen for squamous cells, and this can be seen in figure 2C and 2D. And as you can see, there is high expression seen. Perioperatively, the patient developed atrial fibrillation that responded well to amiodarone. After surgery, she was stabilized and discharged on Xarelto, a statin, a beta blocker, and colchicine. And so it was clear to us that the mass in this lady likely originated from her cervical cancer. Although the most common sites for cervical cancer metastasis would be the lungs, the liver, or the bones. The heart would be an uncommon site. But when it does metastasize to the heart, presentation can vary depending on the location of the metastasis. Patients may present with nonspecific symptoms like chest pain, fever, chills, weight loss, malaise, shortness of breath, and so on. Sometimes the patient may present with characteristic symptoms of specific diagnosis, such as congestive heart failure, tamponade, cardiac arrhythmias, heart blocks, and any pathologies of the chest. Because of the varying presentation and the uncommon metastasis, the diagnosis may get missed. And if patient presented with no signs or symptoms that would warrant any kind of imaging, then the diagnosis of cardiac metastasis may be missed. In our case, for example, because the patient presented with myocardial infarction, imaging was likely to be done to further evaluate post-treatment. This patient was seen on follow-up outpatient, and an echo outpatient showed that the mass had continued to grow and had invaded the left side of the heart as well. Thank you, that's all.